Is it visible?
Yes, sir.
Okay. So the first ask you, what is pH? What is the normal value? Why should it be maintained within that levels?
It is the power of hydrogen ion or negative logarithm of H plus ion, sir. Normal value is 7.35 to 7.45. For a correct value, it is 7.40.
It should be maintained with the normal limits for proper functioning of enzymes.
Enzyme systems, excellent. So pH is the negative logarithm to the base 10 of hydrogen ion concentration. Maintenance of stable pH is important for enzyme functions, membrane excitability, and energy requirements. And the normal value is 7.35 to 7.45. What is Henderson-Hasselbalch equation?
It is between pH of acids and their pKa, sir.
Okay.
That log of
And the
acid by base.
and the pH is equal to the pK of the drug. There will be 50% of the drug will be ionized and 50% will be unionized.
That is dissociation constant. What you are talking about is dissociation constant. But Hasselbalch has a relationship between pH, dissociation constant, and concentration of weak acid and its base salt. Okay, all the three are combined in that. So the pH is equal to log acid by base. That is the equation, Hasselbalch equation actually. It describes the relationship between pH, dissociation constant, and concentrations of weak acid and base of salt. So how does body maintain pH within the normal range?
It is by two organs mainly. One is the lung and the other one is the kidneys. Either by conserving.
By buffering systems. Buffer systems.
Buffer, three mechanisms: buffering, compensation, and correction. Okay. What is a buffer and what are the buffer systems in the body?
Buffer is which resists the change in the pH. Sir.
What are the buffer systems? Without itself changing anything, it is the one which resists the changes. What are the buffer systems which come into effect to maintain normal pH?
Sir, it is
Hemoglobin,
Bicarbonate hemoglobin and protein.
phosphates.
So buffer is a substance which resists a change in pH by absorbing or releasing hydrogen ions itself. Okay. So the common buffer systems in the body can be extracellular or intracellular, carbonic acid or bicarbonate buffer, hemoglobin, plasma proteins, and phosphate buffer. Okay. So their location can be extracellular, intracellular, and the chemical nature is carbonic acid or bicarbonate buffer, which is a very, very exhaustive and excellent buffer system. Hemoglobin, plasma proteins, and phosphate. Four things you have to remember. What are the compensatory mechanisms used to maintain pH? That is the second part. First part is the buffering system. What are the compensation mechanisms to maintain normal pH?
Immediate compensation is by lungs, sir. It's respiratory compensation. Over a few days, the kidneys will take over.
Come. Fantastic. Respiratory acts swiftly by control of plasma, partial pressure of CO2, but it cannot correct totally. So renal compensation occurs slowly by excretion of hydrogen ions and reabsorption of bicarbonate ions. What is the meaning of base excess, which you normally see in your ABG reports? What is the definition of base excess?
So, it is the amount of bicarbonate needed to maintain the pH to get back the pH to normal.
Okay. What if the patient is in alkalotic state? Then do you require bicarbonate then? If the patient is acidotic, you require bicarbonate. If the patient is alkalotic? then you
It is
require
the number
hydrogen
of
ions.
addition
isn't
or
it?
removal of hydrogen.
So it can be both. Base excess or deficit is the amount of acid or base required to restore the pH to normal of a liter of blood at a PCO2 of 40 millimeters mercury and temperature of 37. This is the definition of base excess, or some books say base deficit. This is the amount of acid or base. If it is alkalosis, you require acid. If it is acidosis, you require bicarb. So required to restore the pH to normal of a liter of blood at PCO2 of 40 and a temperature of 37. So it will be negative in acidosis. That is, bicarbonate will be washed out. So you always get a negative value, which some people call as base deficit. And you get a positive value in alkalosis when bicarb is very high. Okay. Right. Here comes a case scenario. A 48-year-old man presents with altered mental status. Patient is very agitated and dexmedetomidine is started. After 1 hour, he spikes fever 102, still agitated, trying to climb out of bed. He is intubated and a lumbar puncture is done. Lumbar puncture shows no WBC and no meningitis. Labs show acute kidney injury and elevated creatinine kinase levels. Patient has been taking SSRI, serotonin, selective serotonin reabsorption inhibitors, and baclofen, and working diagnosis of serotonin syndrome is established. After 3 days of sedation, a sedation vacation is attempted. That is, you start reducing the sedation, and the patient becomes extremely agitated again. The patient is started on antipsychotics, and the sedative vacation is again attempted for the next 3 days with no difference in patient's mental status and agitation. He started on again dexmedetomidine, and the sedation vacation is attempted again with no help. What is the best next step to make the patient all right? The options are: restart baclofen, extubate the patient on ketamine infusion, extubate the patient on fentanyl infusion, extubate the patient on propofol infusion.
Extubate on ketamine, sir.
Ketamine, no.
Extubate on
Already he is
fentanyl.
agitated.
Fentanyl, sir.
Extubate
That's a
on
clue. He has
fentanyl.
already been taking one drug which is given here.
Baclofen.
Restart baclofen.
Restart baclofen, because patient has been taking that. Why A is the choice as right answer? The reason is the patient is likely withdrawing from baclofen, which should be restarted. So all this agitation is withdrawal of baclofen. Now, what is the advantage of using dexmed to calm the patient as a sedation?
So now,
Conscious sedation.
Huh?
Conscious sedation, sir.
Conscious sedation. Anything else?
It's
Is it
also
a long-acting drug
neuroprotective.
or a short-acting drug?
Context-sensitive half-life is short, sir.
Short. What about respiratory depression?
Does not
much.
cause any.
So the delirium and agitation controlled on dexmedetomidine. The medication does not suppress the respiratory center, so the patient can be extubated while on continuous dexmedetomidine infusion also. Okay, that is the advantage. What are the indications for antipsychotics and analgesics in this patient? We started on antipsychotics.
Because the patient is very agitated.
Agitated, yeah. If the patient is getting agitated and delirious, antipsychotics can be tried. If anxious, anxiolytics can be tried. But if in pain, you have to give low dose fentanyl or morphine to correct the pain. How to prevent and treat any withdrawal syndrome? What is how to prevent and how to treat two components of withdrawal?
Multidisciplinary.
First of all, attention should be paid to home medications. You must know what all the medications he has been taking and whether they have been clinically permitted and whether the patient is on any anxiolytic, antipsychotic or any chronic pain medication. That should be continued. Then it can prevent the withdrawal. And then once comes with that, patient will be sedated and you have to restart it in a timely fashion to prevent the withdrawal. Okay. So continuation of the home medications and restarting if it has been stopped are the two methods of managing the withdrawal syndrome. What is Helsinki Declaration on Patient Safety and where was it launched? Heard about this or not?
No, sir.
No, sir.
Okay. So the Helsinki Declaration on Patient Safety in Anesthesiology is a document that outlines key principles and standards of safe perioperative care, especially focusing on the role of anesthesiologists in minimizing risk and then ensuring safety during surgery and related procedures. This was launched in the Euro Anesthesia Congress in Helsinki, Finland, and is considered a significant milestone in promoting patient safety within the field of anesthesiology. Okay. The key points in Helsinki Declaration and who launched it, of course, where was it launched and who launched it? The focus on perioperative care, that is the first key point. So declaration emphasizes that critical role of anesthesiologists in ensuring patient safety throughout the entire perioperative period, including preoperative assessment, anesthesia administration, surgery, and postoperative recovery. So all these things, perioperative care is the first focus. Implementation of standards. It recommends specific practice and standards that institutions providing anesthesia should implement, such as proper monitoring, clear protocols for managing complications, and adherence to best practices of medication administration. And third thing is collaboration with stakeholders. It is declaration encourages collaboration with anesthesiologists, with other health professionals and patient organizations and regulatory bodies to promote patient safety initiatives. And it was launched by ESA and EBA. What is ESA and EBA? Any guess?
European Society Association.
Excellent. European
Society of
Society and the European Board of Anesthesiology. Okay. European Society of Anesthesiology and the European Board of Anesthesiology are the primary organization behind the Helsinki Declaration. Name the parts of a typical vertebra.
Vertebral body, spinous process, transverse process,
Pedicle.
Lamina.
Pedicle, lamina, articulating facet,
and the central portion. This one.
Central.
What is this? This is vertebral canal. Okay. So this is the body. This is the pedicle. This is the transverse process. This is the lamina with the articular facet. This is the spinous process, and this is the vertebral canal. Okay. What is shown here?
caudal block, sir.
Caudal is here. Caudal. This is the opening
No,
for
sir.
caudal. This is something being done at the L5S1. Intervertebral foramen.
Taylor's approach.
Taylor's approach shows anatomical landmark for Taylor's approach to subarachnoid block. What are the indications for this approach?
Rheumatoid arthritis, classification of the
difficult
spine with deformed spine like scoliosis or arthritis. Okay. So the example is like this, this is the Taylor's approach which has done the how would you diagnose and treat total spinal? What is total spinal?
A high level spinal, which will cause respiratory compromise and even cardiovascular collapse also.
Collapse. Okay. Bradycardia, hypotension, nausea, treat with atropine, ephedrine, and phenylephrine. Tingling of hand with progressive weakness of hand grip, reassure patient, reverse and lumbar position. That is, head up should be given. And the patient may complain of difficulty in breathing, difficulty in speaking, and may also desaturate. So, airway, oxygen supplementation, may require intubation and ventilation. Blurring of speech, sedation, loss of consciousness, call for help, airway breathing circulation approach, RSA with intubation and ventilation, circulatory support with sympathetic pneumonia. What is that? What is toxicity ratio and what is its value for lignocaine and bupivacaine?
CNS ratio by
CNS by
Cardiovascular ratio.
so it is a ratio of
Okay.
LA drug concentration in blood produced CNS effect to CVS toxic effects. It is 3 for bupivacaine and 7 for lignocaine. What is shown here?
EMT.
What worked in cardiac anesthesia so far? Is a display in the monitoring the intra-aortic balloon pump machine. Okay. What is IABP?
Intra-aortic
balloon pumping.
Aortic balloon pump. Intra-arterial blood pressure also is a temporary coronary and systemic support device. What is the basic principle and physiological effects of IABP?
Sir, it assists the left ventricular function, sir. So it
Helium
during,
is used to
the
inflate
balloon inflates during
diastole.
diastole, so as to increase the coronary perfusion,
Coronary
and during,
perfusion. Synchronized
Diastole
during
counterpulsation.
systole.
The basic principle is synchronized counterpulsation is the basic principle. Inflation during diastole of a balloon at the tip and deflation during systole of a balloon placed in descending. It's placed in the not in the arch, not in the root of aorta, but at the descending aorta level. This helps to improve the myocardial oxygenation supply, reduce the myocardial oxygen demand. What are the indications for its use?
Left ventricular dysfunction, sir.
Cardiogenic shock.
And during weaning from cardiopulmonary bypass surgery to assist left ventricle, it is used, sir.
Okay. Indications with proven benefit are cardiogenic shock, secondary to acute myocardial infarction, refractory to medical therapy, mechanical complications of acute myocardial infarction like MR or BST, refractory ventricular arrhythmias, unstable angina, decompensated systolic failure. Okay. Indications where it may be of some help is high-risk VABG, cardiac patients on non-cardiac surgery, decompensated aortic stenosis. What are the contraindications for its use?
Sir, aortic aneurysm.
Aortic dissection, aortic shunt, bilateral FEMPOP bypass, end-stage cardiac disease. Relative contraindications are uncontrolled sepsis, aortic arch aneurysm, bill peripheral vascular disease, iliofemoral stent, or coagulation disorder. What are the waveforms that are displayed in this monitor?
First one is ECG, sir.
ECG, very easy. Second, third. The waveform should be during the balloon inflation and deflation. Okay? So ECG trace, middle one is aortic form during augmentation, bottom is balloon pressure waveform. Okay? So these are the three waveforms that you see. What is the name of the incision shown in the upper picture here? For what surgery this incision is made? The dotted line is the incision. It goes like this. Okay, I'll give you a clue. This is done for heart-lung transplant. So what is the name of the incision? Any idea?
No, sir.
Okay.
Okay, this is called clamshell incision. Okay, and this is used for heart-lung transplant surgery. What is LAS and what is it used for? What is the expansion for LAS? Okay, this is lung allocation score, helps prioritize patients to improve outcomes in lung transplant. Okay. What is ELVP? What is the advantage of this lung transplant? I think none of you have had any exposure to lung transplant. Not done in Mayotte?
No, sir.
Oh, not done in SIMS also?
No, sir.
Okay. So ELVP stands for ex vivo lung perfusion. Okay. EVLP, ex vivo lung perfusion, is a technique that enables transportation, evaluation, and reconditioning of donor lungs in an normothermic state. Actually, if you keep it in ice, you make it to ice cold. But this is done in normothermic state, reducing ischemia perfusion injury and enhancing the overall quality and viability of transplanted organs. What is Bode index? Which score in Bode index indicates need for lung transplant? What are the components of Bode index?
So BMI, obstruction, dentish, no, dyspnea.
Dyspnea, exercise tolerance. Okay, B for body mass index, O for obstruction as made out by FEV1, dyspnea as per the MRC dyspnea. What is MRC dyspnea?
Medical Research Council.
Research Council, excellent. Dyspnea scale, and E for exercise calculated using 6-minute walk test. Okay, these 4 things are taken into account, and the score is usually 0 to 10, and the score beyond which a lung transplant is indicated is 7. For Bode index 7, you require lung transplant. Name few pathological conditions requiring lung transplant. These are all upcoming surgeries. Nowadays, you frequently hear after the COVID, so many lung transplants are going on in MGM, in this hospital, Apollo. Okay, these are all becoming more common now. So COPD, cystic fibrosis, interstitial lung disease, pulmonary vascular disease with idiopathic pulmonary arterial hypertension, bronchiectasis, and sarcoidosis. What immunosuppressive drugs are used after lung transplant?
Cyclosporin, sir.
Cyclosporin, very good one. Then all the common 3 which is used for other immunosuppression.
Azathioprine, sir.
Azathioprine or mycophenolate
Mycophenolate.
and corticosteroids. Okay, the trinity, the so-called trinity of immunosuppression. What is seen in this EKG?
Biphasic T.
Prolonged PR.
Prolonged PR interval.
Long PR.
UV.
No, but in some no.
This is a P wave, there is no QRS for that. This is another P wave, no QRS. This is a P wave.
Mobile type 1 block.
A complete heart block. Okay. When the Mobitz type is a prolongation, always followed by a QRS. When there is no QRS, ultimately after 3 or 4 only it will drop. Here every alternate there is a drop, isn't it? So this is a complete heart block. What is the atrial rate and what is the ventricular rate? How to calculate this? Any idea?
Ventricular rate is around 50, sir. 300 by 1, 2, 3, 4, 5, 6 big squares. So 6, 5, sir. Around 50, sir.
Okay.
Ventricular rate.
But in this sort of heart block, will you?
No,
Patient is,
the whole strip, and we'll have to count the number of.
this is the thing. So 1, 2, 3, 4, 5, 6, 7 are there. So 7 into 6,
40.
42. Atrial rate is 85. So we count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. So that is how the atrial rate is counted and ventricular rate is counted only from long rhythm strip, not in the usual way, but between 2 RR intervals. So how are the rates calculated? I'll count the number of PVAs and QRS in the long strip by the bottom. Multiply by 10 if it is a 6-second strip. But if it is a 10-second strip, this is actually a 10-second strip, so it will be multiplied by 6. Mention some causes of complete heart block. What is the other name for this block?
Third degree heart block.
Coronary artery disease, cardiomyopathy, digitalis, beta blockers, calcium channel blockers can cause complete heart block, also known as third degree AV block. What is the treatment?
Pacemaker.
Pacemaker, yes. Why so much of delay? Insertion of a pacemaker. And how to choose which type of pacemaker? It is usually given by this. When there is an AV block, see whether the sinus node is normal or there is a sinus brady or a permanent atrial fibrillation. Then based on that, you have to choose the lead and the mode of pacemaker.
OPC.
OPC, there are organophosphates used as pesticides. What are the symptoms of OPC?
Nicotinic
Cells,
symptoms
sir.
and muscarinic symptoms.
So nicotinic stimulation, muscarinic stimulation, all these things, of course, you know. What is the mechanism of OPC poisoning?
Acetylcholine
Esterase enzyme is blocked, isn't it? OPC compounds phosphorylate the acetylcholine esterase inactivating the enzyme, okay, leading to accumulation of acetylcholine in the cholinergic synapses. So now, how is normally acetylcholine metabolized by acetylcholine esterase?
Sir, acetylcholine esterase has binding sites, the oxime.
What type of binding sites? What are the names of that?
Esteratic
and
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 Ah.
oxime.
It's got a esteratic site and anionic site. Okay, so the normally acetylcholine will get attached here and it will be broken down to acetic acid and choline. This is the choline compound which gets attached to the anionic site. This is the acetyl compound. Will get to esteratic and then that will be cleaved here to become acetic acid and choline. So OPC poison, how is it treated?
supplement of oxygen and charcoal to
So initially decontamination and
Atropine.
atropine.
Very good. So decontamination, supportive therapy, blockade of muscarinic activity is atropine, release of cholinesterase or reversal of cholinesterase by oxime, and correction of metabolic abnormalities, prevention of infection, management of any complications. And sometimes they may need ventilation also because of muscle weakness.
Respiratory muscle weakness.
What are the parts shown here? The dark white arrows. Identify all the white arrows.
oxygen connections.
Sensor and pressure
Okay.
regulating.
I will show each one. What is this pointing at?
Pressure regulator.
Pressure regulator. Okay.
First pressure regulator.
Pressure reducer for nitrous oxide. What is this? It's a closed circuit outlet. Okay? This is the ventilator outlet. This is the oxygen flush. This is the oxygen pressure regulator, and this is the pressure gauge for oxygen. Okay, these are the items that are shown here. What is the working principle of a pressure regulator? Okay,
Pressure.
so this is the working
Volume by
principle.
area.
A large pressure acting over a small area is balanced by a small pressure acting on a large area. So, large pressure is represented by capital P acting on a small area, small a, reduces the pressure, small p, on a large area. Okay. What are the types of oxygen supply failure alarms? These are all basic things.
Auditory.
Yes, electronic and pneumatic. Okay. So there are types. How do they work? What is the working principle? Electronic alarm activated electrically whenever oxygen pressure drops below 30 psi. Okay. Whereas pneumatic, also known as Bowman's whistle, uses a pressurized canister that gets filled when machine is operated. And when the pressure drops, oxygen is let out from this canister to produce a whistle. So it works. This is a very easy one.
Landmark technique of
For IJV cannulation.
IJV cannulation. Two pictures are there.
This is
One is anterior method and
one
then
is posterior
approach
approach.
is a landmark based IJV, posterior and anterior approach. This is posterior approach. You can see the external jugular vein. This is the lateral border of sternocleidomastoid. This is the anterior approach. What are the indications for IJV cannulation?
infusion of vasopressors.
Which we saw lastly. Monitoring of central venous pressure, infusion of irritant drugs, insertion of pacing wires, renal replacement therapy, emergency venous access, parenteral feeding, resuscitation of patients who are intravascularly depleted. What are the contraindications?
There are no absolute contraindications, so, but abnormal anatomy, thrombus in the
Coagulation failure,
Coagulation
uncorrected coagulability. That is the first and foremost important thing you have to remember. Thrombocytopenia, skin infection, anatomical landmark, chemo or pneumothorax on the contralateral side, recent surgery to other structures nearby. Okay. Advantages and disadvantages of IJV cannulation.
so it is more superficial, easily compressible, sir.
Very good.
Easily accessible.
Lesser risk for pneumothorax.
Very good.
Lesser
It can
chances of
be
infection.
approachable by ultrasound, sir.
Anatomically readily visible with ultrasound, can be adapted to accommodate patient size and position, easily access surface presentation. Puncture of internal carotid artery or misplaced line can occur. Pneumothorax is a recognized complication when you go for the anterior approach. Difficult to nurse long term. Few complications that can be caused by that are vascular, infectious, miscellaneous. Okay. So we will go through a little faster all this. What is seen in the X-ray? What do the arrows indicate?
Curly,
Curly V lines and curly
First
A.
of all, what is the diagnosis?
pulmonary.
Acute pulmonary edema. Arrows point to curly A, B, C lines. Okay, they are all curly B lines. So curly lines which are classified as A, B, C lines. What are the types of pulmonary edema?
Cardiogenic and non-cardiogenic.
Cardiogenic and
Cardiogenic.
what is the pathophysiology of the two types?
In cardiogenic pulmonary edema, there is a back pressure from the
Heart. The primary pathology is in the heart, which is causing the pulmonary edema.
Okay. Non-cardiogenic?
It's a pulmonary cause.
There are multiple causes, sir.
Multiple causes. So due to alteration in Stalling's forces, increase in the hydrostatic pressure. Non-cardiogenic, it is due to alteration in the permeability of alveolar epithelium and capillary endothelium. This is the basic concept. Okay. Now, no need to say about the heart and all that. Enumerate few causes of non-cardiogenic pulmonary edema.
Sir, aspiration.
Okay. Direct lung injury, trauma, aspiration, inhalation injury, oxygen toxicity, pulmonary embolism, and pneumonia. Hematogenous injury like sepsis, transfusion-related lung injury, CPB, pancreatitis, heroin overdose. Possible lung injury plus elevated pressures as in high altitude, neurogenic or re-expansion pulmonary edema. How to treat this condition? Whether it is cardiogenic or non-cardiogenic.
Positive airway pressure and oxygen supplement. Treat the
emergency management, upright posture, support oxygenation, oxygen therapy, positive pressure ventilation, reduction of preload by diuretic nitrate morphine, condition PE embolism, basic things to be corrected. And you can remember LMNOP as a mnemonic: Lasix, morphine, nitrates, oxygen, and position. Okay. It is shown here.
Cricothyroid.
Needle cricothyroid. Okay. What is the indication?
So emergency
and
life-saving procedure and situations for why cricothyroid membrane is chosen for front of neck access in emergency.
Only the brain is external.
Easily identified by cartilaginous lamina. It is relatively avascular. Why is syringe with saline attached to the needle?
To confirm the air aspiration.
To help identify tracheal lumen by free aspiration of air bubbles. What is done here?
Percutaneous.
Ventilation.
This is a syringe barrel. This is an adapter. This is the oxygen delivery tube. This is attached to the cannula. It's an emergency ventilation conducted using barrel of 3 ml syringe, universal adapter of 7 mm ET tube attached to oxygen delivery tube, connected to machine outlet and activated with oxygen flush. Okay? That is how you can ventilate in an emergency. What are the complications of this?
Barotrauma and wall trauma.
Technical failure, annular kink obstruction, injury to structure, surgical emphysema. Okay, 42-year-old man is holding area waiting for open reduction internal fixation of right radius. Patient is placed in supine position and anesthetist standing on the head and places the linear ultrasound probe below the clavicle. That is the axillary artery. 30 ml of 0.5 butyritin injected. Local anesthetic spread around the axillary artery is visualized. Which part of brachial plexus is best blocked by an intraclavicular approach for brachial plexus block? The options are the root, the trunk, the division, the cord.
Cords.
Cords. Very good. How many cords are there and what are the anatomical relationships?
3 cords.
Medial cord, lateral cord, and the
posterior cord.
Medial, lateral, and posterior. Brachial plexus emerges below the clavicle. Nerve fibers combine to form 3 cords. These are lateral, medial, and posterior, named according to their relationship to axillary artery. Which level of brachial plexus is blocked by supraclavicular approach, and how is it called in comparison to lower limb block?
Trunks and divisions.
It is called as the spinal block
Blocks
of
both
tempora.
trunks and divisions, is it?
Mainly
Supramuscular?
trunk.
Yeah, trunks.
Mainly trunks, okay. It's also called the
Spinal of the arm.
spinal of the upper limb. Very good. Which nerve of brachial plexus are blocked by axillary approach? Which nerves are spared by this block?
So, median nerve,
Radial nerve and
ulnar nerve is
All the
muscular
branches, okay? The axillary approach blocks the branches of brachial plexus, but the two nerves which can be missed are axillary and musculocutaneous. Okay? What is shown here?
sir, ultrasound guided
Infraclavicular.
Intraclavicular.
Ostoclavicular.
Costoclavicular, correct. Costoclavicular approach to brachial plexus under use guidance by in-plane needle insertion. What is the advantage of this approach over infraclavicular approach?
Sir, here all the nerve groups will be
On the same
lateral to
direction.
the artery. They are
Very superficial. Brachial plexus cords are located more superficially in this position. Helps visualize the plexus under ultrasound because there's no bone here. What is in-plane and out-plane needle insertion?
In plane is we place the needle parallel to the transducer to visualize the entire length of the needle.
Radial, very good.
Out of plane is perpendicular to the transducer.
Transducer, and you will see only a dot.
Tip of
Very
the
good.
needle.
Okay, right. Excellent. So you can see this is the in-plane. You are interesting here, and you can see the entire needle going through that. Whereas here you are going in the middle of the transducer and you are seeing only a dot. Okay, very good. What is sickle cell disease?
It's a type
Hemoglobinopathy.
hemoglobinopathy, inherited hemoglobinopathy.
The hereditary hemoglobinopathy. Okay. What is the characteristic of this disease?
RBCs undergo deformation when exposed to hypoxic conditions.
Hypoxic condition. It's characterized by recurrent vaso-occlusion event that cause endothelial dysfunction and inflammation. Vaso-occlusive events result in painful attacks and progressive damage to tissues and organs. So how that vaso-occlusion occurs is by the deformation of the RBCs. What are the categories of pain syndromes in sickle cell disease?
Acute chest syndrome,
Only
ischemic.
those due to the disease itself, which is called painful crisis, acute chest syndrome, priapism, splenic infestation, aseptic necrosis, leg ulcers, vertebral body collapse, or it can be associated with a therapy like postoperative pain, iron overload, and those independent of the disease or therapy, like infection and trauma. So these three categories are there: caused by the disease, caused by the treatment, and independent of disease and therapy. How is acute pain of this vaso-occlusive crisis managed?
hydroxyurea, sir.
Only one thing? Only
Sir,
hydroxyurea?
hydration, oxygen.
Oxygenation.
All the things. In patients with moderate to severe pain, initial therapy is morphine, probably within the first 30 minutes. And in cases crisis adequate individualized, paracetamol and other anti-inflammatory drugs, and adjuvants like hydration, laxative, antihistamine, antiemetic, IV fluids, and oxygen in case of hypoxia and anxiolytics. Non-pharmacological approaches are massage, acupuncture, yoga, meditation also can be employed. Okay. What is this?
Sir, ultrasound guided popliteal sciatic.
Popliteal nerve. Very good. Two pictures are there.
One is lateral position.
Very good. One is lateral, one is prone. Excellent. Posterior approach in lateral and prone position, in plane insertion of the needle. Always mention the in plane or out of plane approach also. Describe the technique and use ultrasound anatomy when you want to do this. How do you first start doing this?
We start at the
So we
apex of
have
the
to-
popliteal fossa and identify the popliteal artery.
Popliteal fossa is a large area. So where do you start?
Apex of the popliteal fossa.
The popliteal crease. Okay, they begin with the transducer in the transverse position at the popliteal crease. Then first identify the popliteal artery, which is at a depth of 3 to 4 centimeter. Accompanying vein will be popliteal vein will be there, which is superficial to the artery. Then on either side of the artery are the muscles, biceps femoris laterally and semitendinosus and semimembranosus medially. And the tibial nerve is positioned superficial and lateral to the vein. It is seen as a hypoechoic oval or round structure with a honeycomb pattern. Then tilting the transducer caudally brings the nerve from the neighboring adipose tissue. Once tibial nerve has been identified, the common peroneal nerve is visualized slightly more superficial and lateral to tibial nerve. Okay? And the transducer should be held split proximally until the tibial and peroneal nerves are visualized, coming together to form the sciatic nerve before its division. And this junction occurs at a distance of 5 to 10 centimeters from popliteal crease. But anatomical variations may happen, and it may be very close to the crease or some more proximally to the thigh. So it has to be identified by this picture. So this is the tibial nerve, common peroneal nerve, biceps femoris, medial side muscles. First identify the popliteal artery, then the vein, then go laterally towards that to find out this. Which areas are supplied by the sciatic nerve from this level at the popliteal crease level? What is the area, the lower limb supplied from the popliteal fossa level at the sciatic nerve?
Sir,
The entire
leg except
the medial leg and foot. Okay, so this picture will tell you. It is supplying the entire red thing is all by sciatic, and anteriorly you can see the medial portion alone. And which nerve supplies this medial area?
Saphenous nerve.
Saphenous nerve, which is a branch of femoral. Very good. What is the name of the sheath enclosing the sheath CPN and TN called? You are supposed to inject the local anesthetic inside the sheath covering the common peroneal and tibial nerve. What is the name of that sheath?
sciatic nerve sheaths.
By Vidya Madam, anatomist. It's called Volk's sheath. Okay, which is the preferred approach for continuous block by placement of a catheter, and why? Is it posterior or lateral approach?
Lateral, sir.
Why?
So that the catheter fixation is better. The movement does not occur from posteriorly.
Excellent. Fantastic. And lateral approach, if the patient in supine position, is preferred for catheter placement. The biceps femoris muscles tend to stabilize the catheter and decrease the chance of dislodgement. If you go through posteriorly, there is only skin and subcutaneous fat. So the catheter dislodgement is more often occurring there. The second thing is the knee is flexed and extended. The side of the thigh is less mobile, and so the catheter will be more stable in lateral approach. The access to the catheter is more convenient in lateral approach than in posterior approach. Which LA drug and what dose is preferred for continuous block using a catheter? Very neutral. Ropivacaine 0.2% bolus of 5 ml initially and repeated every 60 minutes, followed by infusion of 5 ml per hour. Is the method of doing the continuous block. What are the indications for this block? Any continuous catheter technique is for mostly post-op pain, foot and ankle surgeries, Achilles tendon repair, injuries to lateral and posterior calf, pain conditions in the ankle, okay, foot post-op pain relief, all these things are the indications. Okay, that's all. Okay. So exhausted all the waves. Osce. So shall Kamachi?
Yes, sir.
I think
Hello, sir.
we'll have, this is probably the last class for this year. We'll meet in New Year. So until then, I wish you all a very happy and a successful New Year in your exams as well as in your life. So
Thank you so much, sir.
Thank you,
we
Thank
sir.
you, sir.
Thank you, sir.
And
Yes,
safety.
sir.
Thank you very much, sir. Thank you, sir.
Happy New Year to you also, sir.
Happy New Year to
Happy
you.
New Year,
Happy
sir.
Thank you.
Happy New Year, sir.
Thank you very much. Thank you.
Thank you, sir.
We'll sign off this meeting, sir. Thank you, students. Thank you, sir.
Thank you.
Thank you.